thinking, why do we need to actually look for any future monitoring? We already had enough monitoring. We had a pulse oximeter on place, we had a EPG on place. We had so many compliances coming on your graphics of your mechanical ventilator. So why do you really need to know about more in the respiratory mechanics of your patient? See, currently, I have a patient who is on a ventilator in my ICU with a severe ARDS, and I'm struggling to optimize my PEEP. What will be the ideal PEEP in my patient? If I ask that question to many of you, many of us still don't know what will be my optimal PEEP in my patient. We may throw a different theories here and there and say this can be my optimal PEEP, that can be. Optimal PEEP. You need to struggle to probably recruit and then go down or go up to see many things. Okay, there are many studies across to recruit your patient when your patient is refractorily hypoxemic. Whether your recruitment will help your patient or no. If you ask the same question in a severe ARDS patient on the bedside who is there in your ICU, you don't have a specific answer whether your recruitment will help your patient or not help, or it really will harm. Whether it will open up your alveoli or it will over-distend your alveoli. Whether your patient will get benefited by this or not, I am not sure. A part may be beneficial, a part may not be. Half of your lung may get over-distended, half of may get over. What will be your upper limit of plateau pressure? There are a lot of theories and guidelines from ARSENATE trial that your plateau pressure need to be limited to 30. Then over the last maybe half a decade, we are listening that it's not just only plateau pressure, we talk about driving pressure. And we also came across that physics where you are talking about a mechanical power of your lung. So we are saying not just a plateau pressure, so you will limit the driving pressure. The driving pressure has to be as low as possible, maybe below 15. Your total plateau can be as high, can it be 30, can it be 35 or 40. But as long as your plateau pressure, your driving pressure is less than 50, it's fine, your PEEP can go up. Now we are not sure about what will be our plateau pressure in a patient who is very moribundly obese. His lung wall or his chest wall and obesity, his abdominal body apparatus is landing up a lot of contribution to that elastance and recoiling of your chest wall. Spontaneous breathing effort became a standard nowadays. We are not paralyzing many of our patients except on the day of intubation or an early part of 24 to 48 hours. Later on, we are just leaving them onto a spontaneous mode with their own efforts. We are just sedating them. And these kind of spontaneous efforts, when they are awake, when they are hypoxic, whether that is going to harm those patients by an extra high tidal volume inspiratory efforts or by causing a strain and stretch at the lung area, which are actually very low compliant, compared to their area, which is at a very high compliant. The lung will be heterogeneous in ARDS. So we really don't know the spontaneous effort, are they harming that patient or are they benefiting that particular patient. We do talk about weaning is easy with the spontaneous mode. Stopping muscle relaxant can help my patient in recovery from a ventilator. Critical illness polyneuropathy can be low. And right now we are talking about whether to only sedate, paralyze fully, paralyze half. We may theoretically discuss many of the things, but when it comes to a patient who is on ventilator with a severe ARDS, after third, fourth day, the moment you drop the relaxant, drop the sedation a bit, you start seeing the descent coming. So how do we actually get to optimal sedation, optimal relaxation in those patients till what duration? Still, all these questions are unanswered. You don't know what is your optimal PEEP, you don't know what is your optimal driving pressure, you don't know your optimal plateau pressure, you don't know whether to sedate, paralyze, you don't know which lung will get better, which lung will get harmed. So these are all the questions which are still unanswered. We are struggling with all the evidences. You see the ARSENATE trial which talks about the FiO to PEEP ratio, all are arbitrary. In your patient, it may be different. So where do we go now? We need a personalized mechanical ventilatory strategy. Your patient may need a PEEP of 18, contrary to 12 in the ARSENATE trials chart. Or your patient may need a PEEP of only 8, contrary to that. You need a personalization of your patient. You cannot just rely on a table. That may be yes for an initial part for a beginner, but it's not true for an expert critical care specialist who's on the bedside. He needs to optimize to get a personalized, individualized peak for that particular patient. How do we get it? Invasiveness being slowly getting out. You talk about a PA catheter, you talk about an esophageal manometer, we slowly say no, not invasive. We've got to less invasive. We need a ultrasonography, something on non-invasive, and that should give us more and more information. So we are going for that. Then evolving technology, evolving AI, evolving interpretations. So that will probably, we will go through some of the new technologies we are evolving for liberation and optimizing the ventilation. And trends today are in support of allowing patients to have a spontaneous breath. That's become a bigger challenge for us. To allow the asynchrony to deal with these patients who are already struggling with a ventilator when you are stopping relaxant or cutting down the observation. So these are our challenges, and that's the reason why probably we may need a future respiratory monitoring, which we will be discussing more. So probably we will look for some of these reasons, enhance understanding of pathophysiology, get a diagnosis, get a management strategy, and you know the response to the drugs, response to the fluid challenges, optimize your ventilatory strategies, avoid complications by a barotrauma, epileptic trauma, or any of those traumas or a ventilator-associated traumas, and probably also get an early alarm that you are doing wrong side of it. One of the earliest part during my review when I was actually looking for what can be the future is acoustic monitoring of airway patency. What is this? See, the standard guidelines nowadays, what we follow is we do suctioning when we see a patient's endotracheal tube or a tubing is visibly soiled, or there is some indication in some or the other form on the ventilator or the tubing is known. Otherwise, there is no standard what we used to follow in our studentship, like every second hourly, every fourth hourly, every sixth hourly has been dropped. So this acoustic monitoring of airway patency is an added technology which talks about how are the secretions in the lung and the upper tracheal airways. So this will give you a guidance that way to do a suctioning. And this sometimes the suctioning, when you do open suctioning or even a closed suctioning, sometimes de-recruitment do happen. So this is the add-on phenomenon which can give you a acoustic monitoring of airway patency where the secretions can be picked up early. There is a lot of discussion in the recent times. As I said, you don't know how to recruit, whether to recruit or not, what will be our platelet pressures, and to know that, you wanted to know about the pleural pressure. And you wanted to know also about the abdominal pressures, okay? And you wanted to know the diaphragmatic or trans pressures, where there is a difference between pleural pressures and abdominal pressures, gives you the inspiratory flow, okay? But there can be a paradox in many situations. So what exactly we do? So we wanted to measure the pleural pressure by indirect measurements by putting a probe or putting a manometer in the esophagus, and we take that as one of the reflection or a surrogate of pleural pressure. So transpulmonary pressure has been available since 50s, but the challenge was its interpretation and its use in clinical has been in a recent evidences. Where we use this now right now are to assess whether the patient had a daily respiratory efforts, whether there is an asynchrony, whether intrinsic PEEP is developing, whether we need a proper recruitment maneuver in these patients, or probably we also need to go up on a platelet pressures because of very poorly compliant lung wall or a chest wall or abdominal wall. CVP tracing been used as a transpulmonary pressure guidance. See, when you put a CVP and you see a lot of changes happening in your intrathoracic pressure by a spontaneously breathing patient, they felt the negative deflection of a CVP in this spontaneous breathing. If your CVP is keep on dribbling down from 4 to -4, 3 to -8, that kind of pressure shows that you have a very strong inspiratory drive. You are talking about a very high inspiratory drive. By a CVP tracing has been one of the trials where they used a PCL derived injuries in them. So this is again an occlusive pressure based study which suggests that if you do an occlusive pressure study in a breathing patient, the occlusion at the end of expiration and the efforts can be also be in deflection. If you see from flow to airway pressure to esophageal pressure to pleural pressure and occlusive pressure, all been taken into the account, and they have seen the occlusive pressure at the time of end of expiratory expiration can give you an indirect way of pleural pressure. So this is a study where they could actually indirectly saw that the pleural pressure can be given an indirect way by an occlusive pressure. Ultrasound. So we all been going through the lung ultrasound in the last maybe half a decade or more, and different scores has been used in the lung ultrasound. So we are talking about using a lung ultrasound to know whether the patient has a pneumothorax or a pulmonary edema or a pneumonia. Okay. See, there has been an interpersonal variability from individual to individual. You say this B lines looks normal, this B lines looks abnormal, and this pattern looks normal, this pattern looks abnormal. And there are different scoring systems which has been derived to say and predict things that how the lung mechanics are working in these all ultrasounds. And there has been some AI integration in them, which they are saying nowadays what is scoring system and a computer-aided qualitative ultrasonography to detect a pulmonary edema. So now what they are doing is, see, ultrasound has its own software now, which can tell you whether these all images which you have taken in anterior wall, lateral wall, posterior wall are reflection more towards a scoring. They have tried to find out actually a manual way or how we do and compare that with a quantitative ultrasound detection. And they could found that quantitative ultrasound detection of pulmonary edema is more correlating with pulmonary capillary wedge pressure or a cardiac failure with a pro-BNP or a clinical material. So that means in future we probably will get parameters or a AI interventions where you will put the probes in different segments, you will have your own view, but the computer or the ultrasound will give its own quantitative assessment saying your patient probably has a extra vascular lung water more than what is expected. So this kind of monitoring, and probably your anterior segments has been more aerated than posterior segment. That means probably you are ventilating in a wrong way, you are over-distending. So these kind of integrations of AI will be a part, or the quantitative integration will be a part in the future in very coming, in very short period of time. So B-line quantification. So this has been again a common debate. One of your consultants says, I saw 2-3 B-lines that looks normal. The other consultant feels no, there are 5 or 6 which looks probably abnormal and they are more than what is required. So it's more probably a pulmonary edema. For that, there is an ultrasound assisting by a mechanical artificial intelligence. That will tell you probably this is more of a pulmonary edema than not. So this kind of integration will be an integral part in the future. So the other part of the talk is the diaphragmatic monitoring. Okay, we are talking about a diaphragmatic expansion, diaphragmatic movement, weaning and its role, and diaphragmatic paralysis during our weaning and a continuous. So diaphragmatic continuous monitoring will be in the future as a part of your respiratory monitoring in your all the ICU patient. And this is one of the Respiratory DTX is one of the company which actually developed this, which will continuously monitor your diaphragmatic movement and give you clues. How is your diaphragm functioning? Is it contracting well? Is the adequate contraction is there, or there is a difficulty already? And are you dealing with some diaphragmatic dysfunction or a weaning challenge? And this is how it actually works. So it will get into you will have a continuous monitoring through the probe, and it will take a feedbacks, and that will be deflected in your monitor as its contraction. So this will be ongoing continuous process from your day one till your weaning. So that in between, whenever you see a diaphragmatic dysfunction, you get a clue that you may deal with something else. So the current status is the technical development of prototype has been completed and the design has been frozen. The clinical feasibility studies are already done in Europe. So there is probably ongoing France studies which say the clinical evidence developed studies which has already been concluded in this. So probably this will be a tool added to our armamentarium in monitoring the diaphragmatic function. This other part of my talk will be electrical bioimpedance tomography. This was a kind of a big noisy area right now into the respiratory monitoring, and this can actually be used in reconstructing many resistive changes. What we have been using as a cardiac output by putting two electrodes for an electrical bioimpedance. The same thing has been replicated, has been reflected in the respiratory mechanics. So this is how it actually happens, like what we use in an electrical bioimpedance and a cardiac output monitor by using a complete circled electrodes, and this will give you a continuous monitoring of different respiratory phases, inspiratory, expiratory efforts, lung expansion, which area is aerated, which area is not aerated, by a continuous electrical impedance tomographic method. So these are the evolution in the future. So this is how graphically it will look like on your monitor, like a ventilatory graphics, where you will see this happening from inspiration to expiration, how the lung expands, which part of the lung expands. So this will be a part where you will see different functioning of the lung. So this will be a graphic representation of different parts where you will see what is happening to your PEEP, intrinsic PEEPs, compliances, and lung volumes. The pneumothorax can also be easily detected. There were studies which are suggesting that even the smallest amount of pneumothorax, like around 50 ml, can also be detected by these different technologies, different techniques. So regional oxygenation is again by infrared spectroscopy, where we pick up the tissue oxygen to detect monitoring. Where right now we are talking about pulse oximetry and perfusion indexes by a pulse oximetry continuously, both perfusion and oxygenation. We'll talk about near infrared spectroscopy in the future about the tissue hypoxia, tissue oxygenation. Wearable sensors, this will again be an automatic tracker which will be used for the continuous respiratory rate and all the respiratory monitoring, which will track in your patient and will be given to you by an automated system to your cell phone or your digitally, so that you will be keep on monitoring them. So there are a lot of studies led by the nurse-led monitoring in UK with this cost utility of a continuous monitoring of automated respiratory wearables. Like nowadays, we are seeing a lot of wearables coming from the health, including your all smart watches having a lot of integration of your heart rate, ECG tracking, abdominal rhythms and all. Similarly, respiratory pattern, respiratory rate, respiratory drive, all can be an integral part of these wearables. So to take home, see, we may be having a lot of respiratory monitoring yet. Still, in spite of all these information available in studies, we are still struggling to get an optimal peak. We need to struggle, individualize. Probably also, if you look at personalized way, what your patient needs, how much peak your patient needs. In a similar way, it has to be less invasive, it should be cost effective, it should be reproducible. Okay? For that, I see lung ultrasound by different scoring methods, by different algorithms, which are automatically integrated in your system. You go to the lung ultrasound, scan for pulmonary edema, AI integration will give you an idea that what is the chances that your patient, these are all snapshots which you have taken from the lung ultrasound suggest that your patient is having an extravascular lung water which is significantly higher than what it should be, so you will be restricting. What is this suggesting? Is there any pneumothorax? Is it suggesting something like an interstitial pattern? And what are the risks that or chances that this patient has the same problem by your ultrasound scoring system and ultrasound integration to AI? Then you see a diaphragm movement can be a future monitoring tool. See, we all know, we all do our different studies on diaphragmatic excursion, diaphragmatic movement. We only do when our patient is struggling to get weaned. But if I monitor the same diaphragm from the beginning, function of the diaphragm, contractility of the diaphragm, can that give an idea that whether I am in a correct track of muscle power or I am losing the diaphragmatic function? And the diaphragmatic continuous monitoring can be a way forward in future as one of the tools. Esophageal monitoring, we are all talking about that. We need to know what will be my ideal flight pressures and transpulmonary pressure, and how do I indirectly get a surrogation. Probably some of our ventilators already integrated this, like you will have a port in the esophagus and that gives an indirect transpulmonary pressure or a pleural pressure, so that will be a future in many of our ICUs as a part of it. Electrical impedance tomography, as I showed you, the different diagrams are coming in a big way, and those can be a future by different respiratory monitoring. As I said, the pulmonary, even you are a pneumothorax, as small as 50 ml can be picked up in 3 to 5 cycles. Initial 5 cycles of your respiration, your electrical impedance tomography will warn you that you are dealing with a pneumothorax, please address it. So it will be so sensitive. And PCV and whatever we are talking about, patient spontaneous efforts, which are actually dragging a tidal volume of 900 ml or 1000 ml, what this can do because of hypoxia, because of air anger, when they drive such a high tidal volumes, the healthy lung may get overextended or overdistended, and the diseased lung may not open at all. So this kind of shearing force, which we were talking about only in volume targeted ventilators, can also happen in an individual who is on a spontaneous mode of ventilation or spontaneously breathing. So to prevent that, or to prevent a ventilator-associated lung injury, we probably need all these mechanisms together to probably make our respiratory monitoring better and keep our patients' lungs safer by the time you extubate and be in them. Thank you. The wearable respiratory monitoring system, I think, is more for a non-intensive care setups like HDU or a step-down ICUs where you are being not closely monitored, so they can be indirect methods to actually alert you. But whereas the others which I spoke about, electrical impedance tomography or your diaphragmatic monitoring, these are all being studied in a real intensive care sicker group of patients who are being paralyzed or sedated earlier, and then they kept on tracking them what happened.